Goldsmith, our reporter who covers aging. And folks.
All right, thanks, and good morning to our partners on Zoom. This report from NASEM we're talking about is a big deal. It's supposed to be a successor to an earlier Institute of Medicine report in the 80s that brought about significant federal legislative change in 1987. Dr. Sloane served on the committee that spent 2 years assembling the new report as COVID rampaged across the country. As an opener, here are the 4 words that panelists use to describe the U.S. nursing home system: ineffective, inefficient, fragmented, and unsustainable. We'll turn things over to Phil to put that language in some perspective and to talk about the report in general.
Well, thank you. I would start out by saying the Academy staff made a point of coming up with words that they thought would catch people's attention. And certainly have worked to craft recommendations that would improve effectiveness, improve efficiency, deal with some of the fragmentation, particularly the financial fragmentation, and then recognize that the fact that nursing homes are not going to go away. And so the sustainability is something we need to have. The committee came up with recommendations in 7 areas. The tome they developed was over 600 pages long, so we're just going to be talking very briefly about it. But the 7 areas of recommendations were: number 1, person-centered equitable care that ensures health, quality of life, and safety. That's a general. And it has a lot of sub-recommendations under it, including one that I would highlight because we did talk about it earlier. More home-like design, meaning smaller units, private bedrooms, and bathrooms, because this was shown to reduce infection contagion. That was the area number 1. Number 2 was well-prepared, empowered, and appropriately compensated workforce. Another area clearly needing some improvement. Third was increased transparency and accountability of finances, operations, and ownership, in recognition of the fact that there are often unseen and unknown owners or operators or groups that are collaborating with them, such that the finances of nursing homes is often very obscure. And in addition, recommended number 4, a more rational and robust financing system. And 5 and 6 have to do with quality. Number 5 was a more effective and responsive system of quality assurance, which really addressed the survey process and the oversight by CMS. And area 6 was expand and enhance quality measurement and continuous quality improvement, and come up with some media methods of doing that. And 7 was enhanced use of health information technology, recognizing that nursing homes were left behind when there were legislation and financial incentives to improve the information technology in hospitals and in primary care practices and other medical practices. So those were the general areas, lots to talk about.
Okay, great. Thanks, Phil. And Heather, what can you tell us? These are pretty high-level recommendations. What can you tell us at the ground level that would help our readers and viewers deal with the system, and in particular, perhaps find a good nursing home for a loved one?
Sure, Tommy. Thanks for having me here today. Just to kind of set the stage a little bit about nursing homes and what that means in North Carolina. Is in North Carolina, we have a little over 425 nursing homes, which are licensed to serve just over 36,000 residents. So, and this is skilled care. So I know most of the people on the call kind of know the nuance between nursing home and adult care homes or assisted living. But what we're really talking about is those individuals who are in need of post-acute care after a hospital and skilled rehab, and also long-term care with a medical care need. So I just wanted to kind of set that stage. And really this report comes at a time that it couldn't be more important. This is a critical part of our long-term care continuum. And at a time where we know the fastest growing population in North Carolina is those 85 plus. In the next 2 years or 20 years, we will see a growth of 116% of that 85 plus population. So we know that high level of care that's going to be needed for the oldest of the old. And as really people are looking for whether it's skilled rehab care or long-term care for themselves or their loved ones, these recommendations will help set the stage, and particularly the quality piece and the transparency to help support families look for care and get the data. And so there are some specific recommendations on how to make it easier for individuals to locate the care, about quality, about when there's just the number of facilities, the compare, nursing home, Medicare, compare, provide some of that information. And there's a lot of information on nursing homes, but it's very fragmented, just like the payment system. And so making it more consumer friendly. Oftentimes when families and individuals are looking for long-term care, they're in a crisis situation, maybe haven't planned for it, haven't scoped out facilities. Often it's kick-started by a hospitalization. And so you're in the hospital and then you need to have some rehab care and are often forced to make quick decisions and haven't had the time to investigate and look. And so some of these recommendations are really from that framework of family and consumers to be able to have access to better information so they can make better choices about the care setting and the locations that they want to receive that care.
Okay, thanks, Heather. I will humbly say that a recent story of mine on the nonprofit North Carolina Health News deals specifically with some agencies and websites that you can look at and get some idea. However, most people say the best thing you can do is visit the home, and if you can do that unannounced, so much the better. Getting back to some recommendations, and perhaps Phil, you could deal with this. One of them says that the system is too focused on the medicalized approach, which is a difference between skilled nursing and assisted living. But how do we make them more resident-centered, and can we ramp up the psychosocial side of care?
Well, thank you. That was certainly one of the many emphases of people on the panel. I guess, you can't get away from the fact that nursing homes serve people with many medical care needs and many healthcare needs. And so they're going to have robust healthcare and healthcare provision. The question is, if people are there to live, what can be done to make the facilities and the systems more friendly for making it feel like home, making it feel like every day something interesting happens, that the people feel cared about and feel like the care is personal. And frankly, it really, to a large measure, gets down to staffing. And so there was a lot of emphasis on improving the staffing that are psychosocial related, people like social workers, but also improving the nursing assistant and nurses, because if they have time and they have training, that's really where the majority of care and interaction is going to come.
Okay. As the report says, COVID put the spotlight on something that was already an issue that Phil just raised, the shortage of staff, including direct care workers, that is CNAs. And they, during our preliminary discussions, Phil pointed out that they don't have as strong advocates as other groups of professionals. So Heather, what's being done or what can be done about the shortage of CNAs?
The shortage of CNAs is definitely an impact on nursing homes. And, right now we're seeing a very low census in our nursing homes in North Carolina and nationwide. Pre-COVID, that occupancy rate was around 83%. Now we're at a 75% occupancy rate, depending on the source that you look at. But what we really know is there are not enough staff, and that limited occupancy rate is really driven because of the lack of nursing assistants and other direct care workforce. So we have the need for workers, and we have the need for having more care, but because of the limitation on workers, it's really driving that individuals aren't able to access nursing homes and creating really a backlog there, which we've never experienced before. And you know, this is complex work that nurse aides and other kind of personal aides are doing, that we really need to change the narrative about that job, that these are, they're complex, that they're providing really personal care. And because of the high acuity in nursing homes and the medical care, they're doing very sort of clinical work that's very hands-on, very medical. At the same time, they're balancing family relationships, they're balancing relationships with registered nurses to provide input, and then they're providing a lot of that just interaction with individuals, right? And we heard a lot about social isolation during COVID and the lockdown, but really on a day-to-day, hour-to-hour basis, it's the direct support professionals that are providing that engagement and socialization with staff. So these are rewarding jobs for people who want that kind of interaction and to make a difference. And they're very skilled. And so we really need to kind of work on that narrative. And the report talks about a well-prepared and empowered workforce. And so the recommendations in there talk about looking and trying to create an environment with more respect, more highly appreciated, enhancing training, as well as peer mentoring and other supports that we can do to provide support for them. We're also looking at things that we can do around providing supports, employment supports, training, loan programs, or loan making it so people aren't having to pay for this training. Most certified nurses assistants are having to go through programs to get certified and paying for that training on their own. These are low paying jobs. The average salary of a nurse assistant in North Carolina is just $13.28. So this is not a job that you're getting a high wage for, but yet you're trying to support your family and pay for your training. And so anything we can do to help offset that and support workers to pull them in and create a higher pipeline, it is welcomed here. And I think what we know is in the very next 20 years, the only other sector of employment that's growing faster than this direct care workforce is the fast food industry. So when we're looking at these vacancies, we need to recognize that we're looking at it compared to sort of the fast food industry and what these have to offer. And there will be in the direct care workforce in the next 10 years, 186,000 vacancies with those people who are leaving, as well as increased need across the time. So this is a fast growing and high need workforce that we need to have in place. So this is the time we need to be working on it now.
Okay, thanks, Heather. I'll interject just from my point of view, there's sort of a sad comment that these skilled professionals are competing with McDonald's and the Whopper for jobs. And this gets to a subject that many family members have faced if they come to see grandma or a spouse and try to get help for a specific condition and no one's around. Phil, I believe you mentioned an ideal staffing level. And I wish you could talk about that and what a difference it would make in the quality of care. It's a softball, but it's a good one.
Well, the committee made it a point not to be able to, not to specify numbers, because numbers depend on the acuity of the individuals. But obviously, if a nursing assistant has 8 people, they can't do as much for them as if they have 6, or even 4. But I wanted to make a comment about the fast food industry. And the fast food industry is growing, but it is more vulnerable, because you walk into a McDonald's and now they've got a computer where you can order, and you've got you got a QR code. You can, there's a, and making French fries could probably be replaced by robots. I mean, there's a lot of things, if we could just make nursing home work attractive, both, by empowering the workforce, training them appropriately, and reimbursing them more appropriately, I think we would solve the problem. It's just, we know that there are a lot of barriers to that, most of which is tradition.
All right, there's also the factor that both government and private industry are creating the equation of how much of the money that goes to the company actually ends up in the hands of the direct care workers and then the senior citizens. But I wanted to move on a little bit. And Heather, we have talked about the changing nature of treatment or care for older people vis-a-vis the role of home health care as opposed to nursing homes. And I wonder if you could enlighten the viewers on that.
Probably 15 years, we've seen a lot of emphasis on expansion of home care services and a lot on looking at home and community-based services. And I think that's really in response to knowing we have this aging, growing population and that a lot of people's preference is to stay at home with the supports that they need. And until this report, we haven't really dived into the long-term care setting as much. And so being able to look at the quality of long-term care is really important, especially in the nursing home settings, because it's a setting that we absolutely need. And we can't have just one type of setting, whether it's at home or nursing home. We need to have a wide range and continuum to meet everybody's needs. And the report talks about person-centeredness, and having a robust quality long-term care continuum is really what we need to have a person-centered care. And so looking at the equity that they provide is important, whether it's in home care or in nursing home settings is really important. So I think that when we look at this continuum, we need and we want to have a robust system, whether it's direct care workforce across settings, whether it's payment across settings, that we need to have or quality measures. So it's really, this is one spotlight that's being focused on this report, and other work has been done and will continue to be done in the home care and home and community-based settings. I will say though that, this is a really lengthy report here, and there's a lot of very specific measures and recommendations, but a lot of these are going to take time. And in the support, just to kind of give the viewers an idea, there has been some funding through the John A. Hartford Foundation. $1.2 million was given to Leading Age, a national nonprofit group, to advance and further these recommendations. So the good news is this isn't just a report that's going to sit on a desk and collect dust, but there is momentum, there is funding, and work that will continue to track as these recommendations get implemented. And you are already seeing some changes from the Centers for Medicare and Medicaid Services around looking at the quality measures on staffing and the impact of that on the star rating system. So these are linked into some other things going on, and I think we're going to continue to see the implementation of these recommendations over the years to come.
Okay, thanks, Heather. I just put in a note, it's important to remember that these facilities are the only home many residents will have until the end of their lives. And it's important to think about these places as their homes. I mean, they've been in nice homes for many years in many cases, and now they're confined to a single room and maybe their own bathroom. But to get back to the report, Phil, you mentioned it as a possible turning point in the broad spectrum of care. What would that new direction ideally consist of?
Well, there are things that CMS can do, and there are things that require congressional action. And I think it's easier for CMS to introduce kind of new survey, new requirements, but it's harder to get Congress to provide the wherewithal if new funding is needed. And I think that's going to be the tough thing, because you know how difficult it is to get anything through Congress these days. I'd like to believe that perhaps the two parties would actually agree that care of seniors is important. And I'd like to comment, because one of the things is everybody would say, well, we could just do home and community-based care because there's such an emphasis on that, as Heather was talking about. But I wanted to emphasize that there are some folks who just don't do well in home and community-based care. For example, people who need daily nursing care It's just too expensive to have a nurse in the home every day. At least in our current system, people who need two-person assist, there's a very rare family that is available with two people to lift somebody if they need to go to the bathroom, or if they, if it takes two people to do it. People who have cognitive impairment, dementia, especially if it's active and medically complex, or they have behavioral expressions that make, impossible for the family to sleep at night, or, anybody who needs 24-hour supervision, it's hard for a family to do that. And it's cost prohibitive to have an individual on a one-on-one basis in a home. So, and the other thing is, families are great, and we learned that families really enhance the care, especially the ones that come regularly. And we learned from COVID that we lost an important part of the workforce when families were shut out of nursing homes. But everyone, families, care staff, needs to be educated on the needs of individuals. For example, what does it take to prevent somebody from losing the ability to walk if they have a lot of difficulty? What does it need to prevent somebody from developing contractures in their joints? There's lots of things like that really are medical issues that require coordination of health professionals, care professionals, and of course, behavioral professionals. Not a simple area.
Great. I have a feeling we're getting close to running out of time. I've always wondered what it's like to say, you have 30 seconds to respond. But Heather, can you give us your sort of wrap up about what we should be emerging with out of this new information?
I think what this report really does is validate some of the work that North Carolina has already been doing around these issues, particularly the focus that we've had on direct care workforce in North Carolina. We've had a coalition through our Essential Jobs, Essential Care, working on this advocacy policy issue for a couple of years now, and have widespread support. And I would say the adequacy of payment reimbursement through the Medicaid system to make sure that we can adequately support and the direct care workforce is top of the list here. And we had, through COVID dollars, an acknowledgement of the work of direct care workforce through a one-time bonus. But we need to continue to further that and look at not only increasing wages, but also developing career ladders and meaningful training so that workers are able to have some career advancement and pathways through appropriate training and curriculum. I would say, from my vantage point, that's already has a lot of momentum in North Carolina, and we'll see that continue over the next year at least.
Okay, thank you.
If I could piggyback onto that, sure. Tommy, we've got a question from our audience, which is, what can North Carolina do to implement the recommendations in the report? Like, what are the top one or two possibilities and priorities for our state at the state level?
I'll turn that over to the panel.
Well, I'm not a policy person, so it's hard for me to know exactly what is most feasible. I would want to mention that the committee is made a point that this is a package of recommendations. You can't have workforce reform without having financing reform. You can't have financing reform without having goal reform and oversight reform. So it's really helpful to think about how to make this package be implementable. Now, at the state level, I think I would turn over to more of the policy folks. What are the areas of greatest movement possible? We just know what the priorities are.
Right.
Okay, Heather, I think one of your jobs is monitoring what's going on Jones Street.
Right, and definitely over the past short session, the reimbursement rates for nursing homes and continuing those, there was an increase related to COVID. And that was extended in the short session, which is really important. Also extended was the reimbursement rate for personal care services as well. And so that really helped extend it, but there was no long-term resolution there. So you're going to see some continued activity. It sounds like there's also some acknowledgement that we need to tie those reimbursement rates to quality and quality measures if things are going to be extended. And so I think that's going to be our real conversation here at the state level. But I think there's also some things that we can do too, and mentioned in the report, in the home-like environment, there are double occupancy rates, and we know that single occupancy rooms do reduce infection. So what about, looking at that and trying to create some of more of that one room, and that was done in hospitals through Medicare, and that may be something that will happen. But I think we're going to see some more conversation around the reimbursement rates and making sure we have adequate payment, that they have not kept pace with the need over time.
Okay. An innovation I saw years ago in nursing home design put, say, 8 rooms close to a kitchen. So residents could go to the kitchen and have a snack during the day, as many of us would like to do. They're more able to walk to dinner rather than having to be wheeled to a far distant dining room in many cases. So things that appear relatively small can have big effects.
The other thing, just thinking, the report that mentions the ombudsman program, I saw that in the chat there too. And looking at what our North Carolina ombudsman program is doing, making sure it's adequate to provide advocacy and mediation to residents. And those are real resident advocates in those nursing homes, and it's a program that's nationwide. But I think, they're important in terms of helping families and consumers know their rights when they're in a nursing homes, and they're not the regulatory agency, and there are some most definitely regulatory recommendations in there. But I think that would be another complement that you might be able to see an expansion of the ombudsman program.
Okay, Rose, how are we doing on time? Should we take a few more questions?
If there's any more questions, we can take them, but right now we don't have any more questions, and we're right at 9 o'clock. When we did our practice session on Tuesday, it was like, oh, this is, it's a lot of time, but it's amazing how quickly these conversations go by. We've designed this series to be conversation starters, really, more than the last word. So we're really hoping that folks we've put a bunch of links in the chat, links to Tommy's stories, links to the NASEM report, links to the Coalition on Aging. So there are lots of resources for folks who've been on this call to avail themselves of and learn more. And if there's any more, if you folks want to do a wrap up, and then I think we can wrap up.
Yes, let me just say I'm pleased to see some very highly informed people in our audience. They know much more about this than I, and I appreciate personally their service to the older people in North Carolina, to the residents of homes, to the people that may be on their way, that are in the continuum. And with that, Heather, anything further from you?
I would just add that, and I think we've kind of alluded to this the whole conversation, but the nursing home setting and industry is a really complex web and of, all of these things. So to be able to have a comprehensive recommendations is helpful, but it's going to take years to be able to implement these and see changes. And so I think that's the thing that we know, that we've got to prepare for this growing population, but we've got to see action now on some of these items so that we can start advancing, because it's going to take a long time to unwind this complex web of solutions.
Okay, and Phil, I feel like we've covered a lot of ground, but is there anything we have not covered or a general observation?
Well, one thing I would say for those who have not accessed the report and read it is that if you Google quality of care in nursing homes, NASEM, you can download the entire report, quality of care in nursing homes, NASEM. That will pull it right up, and it's free.
Okay. Rose, would you like me to conclude, or are you going to conclude?
No, I think we can wrap up here. And again, we want to thank everyone for attending our healthcare half hour. We'll be back in September. And we don't know what our topic will be, but if you are interested in learning more about North Carolina health news, sign up for our newsletter. we'll send you an email twice a week with our headlines. And every once in a while, we'll ask you for a donation. And I'm going to ask you for a donation here. North Carolina Health News is a not-for-profit news organization. We really run on reader donations. And we thank you so much for the support. I can see that there's a number of donors in the audience already. So thanks so much for attending today, and we'll close it here.
Thank you.
Yeah.
Bye-bye.
Thank you. Bye-bye.